Thank you very much. Good morning, everybody. First of all, thanks for the organizers to have this, give this opportunity to Brazil to present their first steps of TasP. It's very nice to be in Vancouver. As Loris mentioned yesterday, Vancouver was inspirational for all of us in terms of the 18 years ago with the heart therapy that was launched here and was straight away implemented in my country and some other countries from 1996. Also, Vancouver is inspirational for what Dr. Julio Montañez is doing with his team here in terms of one of the first places in the world who started to work on treatment as prevention. Julio is an incredible person, very inspirational for Brazilians, except from 2 months from now, during the World Cup, that we're going to break relations for at least 2 months. But after that, we're going to probably go back depending on the results. Also, Vancouver is incredibly inspirational for us in terms of their safe injection room, which is one of the most advanced strategies in harm reduction in the world. So it's a pleasure to be here. I will start for talking about the Brazilian cascade of the continuum of care. And we have a gap that's bigger than France. We have about 150,000 people, that's the data from 2012, that don't know their HIV status. And we have engaged on treatment by the end of 2012, 313,000 people in ARV, and using the cut of 50 copies of viral load, we got 75% of viral suppression. So the novelty in Brazil that we are working from July of 2013 is to push for the combined prevention. Combined prevention means basically the classic prevention strategies, some structural interventions that were the topic of the open session yesterday, and of course treatment as prevention. So in terms of the classic prevention, we are just highlighting, reinforcing the needs for the promotion of condoms, gel lubricants, female condoms, the harm reduction stuff and everything that can help people who is at risk to really get what they need in terms of prevention. In the case of Brazil, I think that the good thing for us is now we are working very hard to focus in the kind of epidemic that we do have. We have a concentrated epidemic in Brazil, and so our tradition in terms of prevention was trying to do everything to everybody. And it's a waste of time, a waste of money, a waste of possibilities of real interventions, and we are trying as much as possible to real focus on the most at-risk populations as much as we can. So we are trying to work together with gay people and men who have sex with men, with sex workers, with transgender, and with the harm reduction people, the people who use drugs. One of the strategies that we are developing, and we did that last year, we are supporting 4 projects in Brazil doing rapid test, that's an oral test produced in Brazil, that you got the results in about 15 minutes, and you read a pregnancy test. It's similar to Oral Quick, but it's a national production. So basically we are training the NGOs that work with transgender, gays, and men who have sex with men, people who use drugs and sex workers, to do the diagnosis and refer people to care and treatment. those projects are paid by the Brazilian government, and so basically we are supporting the right people to get the right high risk. We are also working in structural interventions, so we are working very hard on the UNAIDS initiative of zero discrimination. This is an initiative from the Ministry of Health from last year that we now, in the public health service in Brazil, all transgender people has the right to have their social name in their health system cards. So they don't need to use their male names, but they can have their social names. And this means a lot for a lot of people. This is the President Dilma Rousseff that received the LGBT movement in her palace in June of last year, in 2013, trying to work in a process that the government of Brazil assumes that there is a clear agenda to support gays, lesbian, transvestites, and bisexual. This is also by the end of last year, December of 2013, there was a big human rights event in Brazil, international human rights event, and this is President Dilma Rousseff giving a human rights award by Kayla Simpson, who is a transvestite, and was directly given from the president to her. And I think all these efforts are coming in the direction of trying to fight stigma, discrimination, and work with key affected populations. We also organized last year with an initiative of many partners in the government and some partners in the UN system, like WHO, UNODC, and the International Drug Policy Consortium and some others, a very interesting debate about drug policy in the region, but drug policy in Brazil specifically, to try to enhance the conditions for us to work with people who use drugs. But the novelty, besides what we have been doing in terms of classical prevention and trying to enable the environmental, is treatment as prevention. And so this novelty basically started to be more openly discussed in Brazil from July of last year. We had two fronts that we worked very hard, trying to join all the experts in the country in two committees. One was trying to have a new algorithm for HIV testing, and the other one working in the new Brazilian guidelines. They are completely associated, otherwise, like if you make the diagnosis too difficult and too bureaucratic, you will never get people in treatment. So the new algorithm is, we have 5 different algorithms. The 1 and 2 is to screen and confirm using finger prick or oral fluid. The third one is combine the 3rd and 4th generation of immunoassays as screening and viral load as the confirmation. And the 5th one is basically the classical one that can be developed in some very high-tech laboratories in the country. But basically, the advantage is that 1 and 2 are innovative approach and enhancing testing's accessibility and reduce biological risks, and this is very good for most at-risk populations, for some remote areas in Brazil like the Amazon, and some places that we would never have the classical approach as a solution. So 1 and 2 requires no lab infrastructure, which is, as I said, very crucial for these populations. Pilot tests already underway with key affected populations. The number one is likely to contribute to the sustainability to help individuals to learn their serological status. And the near future for Brazil is we want to implement this self-test in pharmacies still in 2014. So for 3 and 4, we combine the 4th generation of ELISA and the latest molecular biology, and again, it's proven to be very cost-effective in many places where we have the structure to do so. So we also launched, the new algorithm was launched in December of 2013 after 6 months of very intense debate. And the new clinical protocol was launched in the 1st of December by the minister, was published on the 29th of November. We have a complete document and a quick consultation guide that are available online. Unfortunately, so far only in Portuguese. We may have at least a quick consultation guide, a version for the International AIDS Conference in Australia very soon. So basically, what is important in the new therapeutic guidelines is that we want to start antiretroviral therapy for all HIV-positive people, regardless CD4, and that's our direction now. In addition, we define a very clear first line, that's tenofovir, lamivudine, and efavirenz, and we have some flexibility on the first line. In the second line, we refers to the introduction of protease inhibitors into the antiretroviral regime, with the preferred DPI being lopinavir, with ritonavir booster. We also develop iOS, Apple, and Android platforms where every doctor in the country can just download in their cell phone with the guidelines that can be very easy to access all over. So the scope of this strategy is based on the concept of treatment 2.0. So basically is to optimize drug regimens. So we are working to have, from now, a little bit late in the history, but Brazil is now finally almost ready to produce the 3-in-1. But like we are optimizing drug regimens, point of care and other simplified monitoring tools for diagnosis. We are working very hard to mobilize communities all over the country, adopt as the participation of the communities in diagnosis and also in other strategies. We adopted a different delivery system, moreover, decentralizing for public health care and the primary health care, some of the care of people who has high CD4 and it's stable, and of course of this we are counting reducing costs. What else? We are customizing the response work in a concept of hotspot. At least we organized so far 2 hotspots, one in the Rio Grande do Sul province in the south of Brazil, where the number of reported cases is the double of the country, or in the Amazon, where the mortality rate is the highest in the country for AIDS, which makes sense because of the difficulties for diagnosis and referral services. So we're starting by a big national study on PrEP in public health services in 4 different sites, 2 in São Paulo, 1 in Rio de Janeiro, and 1 in Rio Grande do Sul. Intensifying PEP, at least in the hotspots. PEP is in our guidelines since 2012, but we are working hard to intensify now. Enhancing the universal and free of charge access to hepatitis B and C treatment, including triple therapy with first generation of antiretrovirals and antiviral virus that we are providing since April of 2013, and leading a resolution in the World Health Assembly on universal treatment for hepatitis as an extra important tool. So in our classical cascade, we want to intervene in the people who were tested, then in the people who is under care but not in ARV, and then the people who is under ARV but needs to get viral suppression. So we are working hard on that. Those are the first steps, and I thank you for your attention. Thank you.